Good afternoon, everyone. I am Dr Srinivas, DA, DNB, IDCCM, IFCCM, consultant in intensive care medicine, Apollo Hospital, Jubilee Hills, Hyderabad. I thank ISCCM for giving me this opportunity. I This is a topic of CNS imaging for the beginners. CT and MRI help in localizing the lesion in critical and neurological patient who are sedated and paralyzed. So examining them can also be a challenging. CT utilizes ionizing radiation, and through these slices of image and the tissues are obtained, where when the patient is placed on the CT table in a supine position and the tube rotates around the patient in the gantry. To prevent unnecessary irradiation of the orbit, head CTs are performed at an angle parallel to the base of the skull. Slice thickness are usually 5 to 10 mm on a routine head CT, and intravenous contrast is given to look for the tumors or cerebral infections, if any present. And the three types of images which we see on the CT are axial image. Here, which you can see, it is an axial image, and this is a sagittal image, and this is a coronal image. There are two types of windows usually we see on a CT scan. These are soft tissue windows and the bone windows. Soft tissue windows are used to identify any brain parenchymal disorders, hemorrhages, CSF spaces, soft tissue tumors, and bone windows are used for identifying the fractures. CSF has an Hounsfield unit of 0, and all others are equated to the CSF Hounsfield unit of 0. Air has an Hounsfield unit of minus 1000, so it is very darker than the CSF, and bone has an Hounsfield unit of 1000, so it is very bright when compared to the CSF. I use blood can be very bad as a mnemonic to read the CT. So whenever I have a CT scan in my hand, I look for the blood and bleed, and then look for the cisterns if they are any enlarged or not. Then I see the brain parenchyma. Then I see the ventricles and bones, and each one have their own way of interpreting the CT scan. The CT film is divided into little boxes. The first box represents the patient ID. Then this box is in a scout window. Then there are the six main sections which have different, which have been given different mnemonics, which I remember them as X star, smile, Mr. Happy, Mr. Sad, warms, and bean for my convenience. And these are represented here, as you can see. This is the first section taken at the base of the skull. Here we see the globe, temporal lobes, brainstem, and cerebellum. The base of the skull forms the X shape. As we go further, we are at the suprasellar level. Here you can see the both right and temporal lobes which are adjacent to the suprasellar level, and this white structure here is an basilar artery, which is very important artery. And then there is a fourth ventricle here. This is all pons and medulla, along with the cerebellum here and the frontal sciences in the up. And and as we go further, we see the as we go further, we see the flank cerebral, lateral ventricles, third ventricle, thalamus, occipital lobes, calcified pineal glands, and calcified choroid plexus, which appears bright. And this Mr. Happy face is because of the shape of the quadrigeminal system, because of the quadrigeminal systems and the anterior horns of lateral ventricles looking like an happy face. This is one of the best slides for identification of the intraparenchymal bleed and sometimes the hydrocephalus also. Mr. Sorrow face is found with the occipital horns of lateral ventricles along with the frontal horns of the lateral ventricles, and the other important structure which you can see here are the Sylvian fissure, which is the Sylvian fissure here. And then these are posterior limb of the internal capsule. This is the internal capsule which we have mini nucleus over here. As we go further, we see we see body of the lateral ventricles and posterior lobe of the lateral ventricles forming the shape of a worm. Occipital horns of the lateral ventricles are most dependent areas here, most dependent areas over here, which we are seeing. And all the blood which is present in the intraventricular region will accumulate here because these are the most dependent area, and this is the best area for looking for the interventricular hemorrhage. As we go further, we see two parts of the cerebrum looking like two beans, and there is flat cerebri in the upper and the superior sagittal sinus below. This image here shows that there is an acute and chronic SGH. Acute SGH is usually bright in color, and chronic SCH is dark in color. The MRI sequences are many, and we will discuss a few of them. Here, this is a T1 weighted image where it is called as anatomical image, and water appears dark in this. And edema has water, so any edema here appears as dark. When compared to T2 weighted image, this area is bright because there is a diffusion because of the nature of the T2 weighted image. And when we go for the other images like FLAIR, it is nothing but T2 weighted image without a CSF. That is, CSF is minus, and then this FLAIR image is been obtained. Here, SAH looks bright on the FLAIR, and FLAIR is investigation of choice for multiple sclerosis. Diffusion weighted image is very important because here we use this image for the identification of acute stroke, and also it is a gold standard for acute acute infarct core estimation. Infarction edema looks white, so this white here is an acute infarct edema. Diffusion weighted image and the ADC should be read at the same time. When we see a bright image on diffusion weighted image and a dark image on ADC, then it is usually an acute change. But when there is a hyperintense area here and hyperintense area here, then it is usually chronic in nature, and is also called as T2 shine through. ADC and subsequent images are also obtained, but they are very difficult to interpret. And here, infarction edema looks dark. That is, cytotoxic edema looks dark. We will speak about some of the hemorrhages and on the CT scan and MRI, and they can be divided into non-traumatic and traumatic. In non-traumatic hemorrhages, we will speak about the SAH and deep intraparenchymal hemorrhages. In the traumatic hemorrhage, we will speak about extradural hemorrhages and the subdural hemorrhage. This is a 45-year-old man with the worst headache in life. Non-conscious CT was done, and here you can see thick hyperdense material in the suprasellar system. This is suprasellar system, and this hyperdense material extending into the interhemisphere fissure. So whenever you see an hyperdense area extending into interhemisphere fissure, and in the in the systems, then it is most probably because of the SAH. To know the origin of this bleed, we did an CTA which shows basilar artery aneurysm. Here you can see this blob which is showing that the aneurysm have ruptured and caused this SAH. So whenever you see an hyperdense area in the Sylvian fissure, then think of this hemorrhage is because of the MCA origin. Whenever you see hemorrhage in the Sylvian fissure or at the basal cistern, then think of the lower arteries that are the basilar artery and posterior communicating artery. But when we see an hyperdense lesion way up above in the interhemisphere frontal lobe, then think of the ACA as a culprit. This is a 49-year-old male presented to VIA with worst headache, and we thought of the bleed on CT scan. Then we did an CTA and DSA. But in CTA and DSA, there was nothing found. So this is classified as a non-aneurysm perimesencephalic hemorrhage because the hemorrhage is seen on the CT, but it is absent on the CTA and DSA. So this type of hemorrhage accounts for 10 to 15% of all the SAH. Now this is in case of 25-year-old male with an RTA and GCS of 5. So he had an CT scan which shows hyperdense area in one of the sulci, but the GCS is 5, which was not correlating with this CT scan. So when MRI was done, it shows extensive contusions, and this explained the situation. This GCS of 5. So after a few months, this results in a gliosis, that is a dead tissue, because of this extensive damage, and this dead tissue is a non-functional brain tissue. This is an 31-year-old male which we received 15 days back with a GCS of 6/15 and had a clavicle fracture and 6 rib fractures on the right. When we did a CT scan, the fourth ventricle had a bleed here. You can see a small dot at the fourth ventricle, which is represent the bleed. And as we have seen earlier, this area, the fissure is having hyperdense material, so it is diffuse SAH. And then there is also bleed in the pons. This small hyperdense lesion is a pons area bleed. And then there is a SAH over here because of the cistern having the hyperdense area. And also you can appreciate small dot contusions in the corpus callosum. So whenever you see a dot contusions and then a bleed, then it is categorized as grade 2 SAH. And then SAH, if untreated, can have complications like rebleeding and also vasospasm and hydrocephalus. Hydrocephalus can be of two types, communicating and non-communicating, and traumatic SAH usually result in non-communicating hydrocephalus because the bleed will clot, will obstruct the CSF and cause dilation of the ventricle. This is a 22 years old man post accident presented with GCS of 6. When CT scan was done, this is non-contrast CT scan, you can appreciate small hemorrhages, and these are at a place where we see gray white matter differentiation area. So these areas are gray white matter differentiation areas where we find the small dots of hyperdensity. This is characteristic of diffuse axonal injury. The reason for diffuse axonal injury is there will be acceleration deceleration forces during the accident, but at the same time brain will be in stable condition, resulting in sharing the tear of the axon, causing the diffuse axonal injury. So this area is this area, and in the diffuse whenever you find a patient with GCS less than 8 with an abnormal CT, ICP monitoring is indicated for this. EVD is usually placed, and this is a correct EVD placement in the ventricles for draining of the CSF to relieve the ICP. Here you can see this patient having different ICP modalities, and this CT scan shows their placements. This is a 6 years old female who had an injury due to fall, and you can see a lot of pneumocephalus or air spaces in the brain tissue, which are characteristic of traumatic pneumocephalus. Now we will see a patient who is 56-year-old man with a sudden severe headache. NCCT was done usual, and it shows hyperdense lesions at the internal capsule. So this is an deep hemorrhages, and we also see this red circle areas in the MRI, which shows which are at the basal ganglia and thalamus, and this is a microhemorrhage which is seen in the cerebellum. So hypertensive hemorrhages, 75% of them are seen at the basal ganglia and thalamus, 15% of them are seen in the pons and cerebellum, 5% are seen in the centrum ovale, and here you can see all the hemorrhages which are present at the deep tissues, deep brain tissues. And hemorrhages can also be calculated with a formula of ABC/2. And if the patient is untreated, then there will be increased ICP, and there can be herniation. And herniation are of 5 types. These are uncal herniation, transcensoral herniation, subcalcium herniation, and tonsillar herniation. Here you can see transcensoral and tonsillar herniation, and uncal herniation is from above, and then this herniation is from down. Here you see a 25-year-old female presented 6 days after delivery with a BP of 180/100 and cortical blindness. So straight away we can think of a posterior reversible encephalopathy syndrome, but the CT was not very conclusive, so MRI was done. Here hyperintense area are seen at the hyperintense area here are seen in the posterior circulation, mainly in the occipital and the posterior temporal lobes, occipital and posterior temporal lobes. And this is a 22-year-old woman presented with acute onset of left-sided weakness, lethargy. Fundoscopy was done, which had papillary edema, and also she has severe headache. So NCCT was done, which shows hypertense transverse sinuses due to acute thrombus of the sinuses. And these also have an cord sign in the high up levels of the brain imaging. And for this, MR venogram was done, and it showed absent flow in the superior sagittal sinus on the left side. This is the left side, this is the right side. This red arrow shows cutoff of the superior sagittal sinus, which is a characteristic of the superior of the, and also there is anti-delta sign, which is characteristic of the cerebral venous sinus thrombosis. And this catheter angiogram also shows the superior sagittal sinus thrombosis. Now we will move on to this case of a young man who presented with a GCS of 6 and had a hyperdense area on the CT. And this is like a lens or convex shape with dark areas in this area called as fills, and this is an EDH. This is because of the medial meningeal artery tear, medial meningeal artery tear in the epidural spaces, which forms very fast because of it is an arterial bleed. And this patient can go for surgery when the EDH is less than 30 centimeter cube, regardless of the GCS. This is an subdural hematoma because it is eccentric shape, and it crosses the suture line. It is very slow in formation because it is formed by the veins. So on presentation, the patient can also have large SDHs, because on presentation, because it is slow in growing, and surgical intervention are needed when SDH is greater than 10 mm thickness, and if there is a shift of the midline shift greater than 5 mm. So this is a 68 years old female with right hemiplegia presented after 6 hours. Here you can see there is a hyperdense MCA sign, which is classical of MCA infarct, and then there is color change in putamen, which is characteristic of MCA infarct, and also there is loss of gray white matter contrast in the left frontotemporal lobe, which is characteristic of MCA infarct. This is also an MCA infarct, where you can see flare and DW have hyperintense areas. And when MRA was done, here you can see that this MCA infarct is cut off, caused by an infarct. So this is a diffusion image where you can see there is a small image, and this is a large area, which is an penumbra. This is an hyperactive stroke pattern penumbra of a 69 years old male. This is a cerebral blood flow, and this is cerebral blood volume. Penumbra is the cerebral blood flow minus cerebral blood volume. So this area should be preserved by giving thrombolysis. This is an posterior communicating artery stroke, which is typically present here, and on MRA there is an PCA cutoff here. And this is an acute cerebral artery stroke where it is present in the frontal lobes, anterior parietal lobes, and in corpus callosum. This is a patient of a pontine cerebromyelolysis, where, and this is lacunar infarcts are the infarcts where we see here in this small areas. This is an post cardiac arrest patient where you see large hyperdense areas in diffusion weighted image and ADC. This is because of failure of the brain cells because of anoxia and decreased blood supply, and severe ischemic insult involves the brain, basal ganglia, cerebral cortex, cerebellum, and hippocampi. There are two types of edema. This is vasogenic edema and the cytotoxic edema. Vasogenic edema is because of brain destruction seen in the tumors, and cytotoxic edema is seen in the infarct. Thank you all.